it's a difficult way to start off. We have a very powerful technology in coronary calcium scanning, as was mentioned many times yesterday. Most successfully by Matt Ludoff to my right, who did as good a job defending screening against one of our adversaries, Rita Bedford, as good a job as I've ever seen in putting out the data, the massive amounts of data that support calcium's use. The main area that the detractors of the concepts have focused on is radiation exposure. That's one of the main areas. And so the question, is it an issue? Well, it's an issue because it's prominently an issue because it's being raised and in the newspapers and widely talked about. Could I have the next slide? So to just look at what is out there. First, let's talk about, is the radiation dose from different scanners the same? So how much radiation is really associated with a coronary calcium scan? These data that anybody sitting at the back of the room will have a very great time seeing, so I better move up to, are from the MESA trial. And they show, the top scanner it was the most recent version of the EBCT scanner. Then it's a standard, this was a early generation GE scanner. Volume zooms, a 4-slice Siemens scanner. They don't matter too much in terms of those different ones that in general. On the far right, the estimated effective dose is shown in millisieverts. In this MESA publication, 1.7 millisieverts for a coronary calcium scan in the chest. And for the Lightspeed Plus, 3.8 millisieverts. And for the volume zoom, 2.4 millisieverts. A mammogram is on the range, a mammogram is in the range of a millisievert. So we are, and correct me if I'm wrong on that, Matt, I'm saying 1 millisievert for a mammogram. Chest x-rays are much smaller, so when they compare coronary calcium scanning to chest x-rays, you always have to recognize that over the last 20 years, the amount of radiation from a chest x-ray has plummeted. It really changed dramatically. So it's really not necessary, it's not a stable marker. Mammograms have not changed that much. And
I'm sorry, we're going to have to go quickly.
Okay, next slide, sorry.
Yeah, one more minute.
Okay. I'm real sorry. Okay, this is another slide that was published by Einstein, one of the people who talks about radiation the most. And we see a much marked, in all these different scanners, including many major hospitals, a marked variation in the amount of radiation associated with coronary calcium scanning, average of 2.3 millisieverts. So it's a low radiation dose, but it does vary. And people have to be doing this right in order to make sure they're in the lower part of that curve. Next slide. Now, it doesn't matter for oncologic reasons. We don't know whether these low doses of radiation cause cancer, but there's a theory that they might. And that theory is held by many prominent scientists throughout the world. With that, then, you have to extrapolate out on this linear hypothesis that even at low levels of radiation, there could be a cumulative radiation burden. This slide then indicates the number of cancers that might be produced by calcium scanning, depending on the age at the time of screening, and it was assuming that they're scanning every 5 years, what would happen in different ages with different scanners. And you can see that because of the variation of the radiation dose, this does vary all over the map. And from this varying all over the map, couple that with the assumption about how much calcium cancer might be caused, there is a spread in the consideration of how much cancer could possibly be caused. And yesterday when Matt was arguing or discussing with Dr. Redberg, he made a very important point. Whenever you're talking about radiation as a source of risk, you need to talk about benefit at the same time. And if you study patients in the right age group, this risk-benefit always remains in a very, very high level. Next slide.
So Dan, can you go to the conclusion, please?
Yeah, next slide. Okay. Coronary calcium scanning is a highly reproducible method. Next slide. Next slide. Thank you. Okay, there's about a 20% reproducibility error in coronary calcium measurements, and that error can be improved. That error is greater at the lower the score. The higher the score, the less that percent variation.